Start our webinar. The fourth webinar for 2023, the webinar for the Brazilian Journal of Geology. All of you, you're welcome. This is a special area. It's a very relevant subject. Speaking about the use of echocardiotherapy focused, something that really calls a lot of attention for our anesthesiologists. So it's of our interest to learn about this and to the theme, which is the fourth edition this year, which is the fourth week of July, will be available. Same subject. So it's a focused cardiography, also the authorship of Professor Eric and Professor Fabio. It certainly is an opportunity to have a very up-to-date history. So have a big revision according to the state of the art of focused echocardiography. So I would like to ask you to share this with your colleagues. For sure, this webinar will also add a lot to this information with Dr. Eric's class. So I would like to also, before I tell you, pass the word to our moderator from celebrating with our colleagues, with the audience, a victory, another victory of the Brazilian Journal. Recently, we had the publishing of the latest impact factor of the magazine by Clarivate, and we once again had the increase of the impact factor. We already had last time, we already had gone over the impact factor 1 barrier and 1.3, that every article published by the publication, we have a 1.3 citations for that drop on average. So it shows the relevance of the magazine, the impact that it has with the words for the authors that contribute to the publication they have on the science related to the anesthesiology area, intensive therapy, and so forth. So it's a big victory, and we have a long path ahead of us to be able to reach more well-known magazines in this sector, but we are in the group. So this is more important. This is important with the quality as a focus of our editorial council, having a strong scientific focus so that we have the published magazine will be relevant. So that is our idea, our project. So I would like to pass word to Professor Fabio Papa, who is the assistant professor of University of Toronto, anesthesiologist from St. Michael's Hospital in Toronto, and also our associate from the publication, which is strongly contributed to the publication of the publication. We have the honor of having Dr. Fabio and all his knowledge. So go ahead, Fabio. Thank you, Andre. Good evening, everyone. Thank you for your kind words. I wanted to thank you for your invitation, and also I'd like to thank you for being part of this group of associate editors. As a result of what you just said, it's a recognition of all the work all of us do. Good evening, everyone. So as Andre already said, we're going to discuss a little bit about basically ultrasound focusing on non-cardiac surgery, which is a mode that grows, the interest grows more and more. So many of our residents, all of you that are here watching, you also have the interest in knowing what it is, how we can apply this in our day-to-day life, and maybe in a certain way, how we can learn, how we can have access to this new point of care. So we'll have a session during this hour. Before we start,
para colocar suas questões ou no Q&A ou colocar no chat mesmo. Eu vou ficar monitorando.
So I'm going to be monitoring this here. At the end of the discussion, we will open to questions. So it's supposed to be pretty informal. It's to be pretty practical. I already saw Eric's room is more than qualified to speak about this. So I hope it will be a very interactive class at the end of the discussion. So without further delays, we'll present this station focusing on non-cardiac surgery echocardiogram. So our Eric Lineburger is a great friend. He is a supervisor for the residents of the São José Inticiúma Hospital, also professor of anesthesiology and University of the extreme south of Santa Catarina, also associate of the Brazilian Journal, and also he is an instructor of the HTS SBS. So Eric, once again, thank you for your participation. So I'll pass the word to, so go ahead. Good evening, everyone. So, congratulations to everyone. So, we will start talking about this subject, which is part of our day-to-day life. It's great to have Prato moderating this session. So, congrats, Fabio. Thank you for the impact factor. I'm thinking to Fabio, Dr. Fabio Papa, who just mentioned this big conquest that we had. So I'd like to start sharing my class, working this subject, which currently is important.
Inteira?
Sim, tranquilo.
Ótimo. Então tá. Então,
So
nesses minutos, vamos conversar sobre ultrassom focado
so we're gonna speak about focus.
não cardíacas. Eu não tenho conflito de interesse com a apresentação relacionado à indústria, dos aparelhos e nada nesse sentido.
And devices in the sense
Ele, quando a gente considera a insonação,
when we think about how things first off part of the anamnesia and after the physical exam, consider this the fifth pillar of the physical exam. So maybe we had the ultrasound always as sometimes a key exam, but we can't forget that is a complementary test of anamnesia. So we have the expression percussion palpation. So there is a lot of confusion. People talk about this new stats that are actually adept of this idea that will be the fifth pillar of physical examination. So in the perioperatorium,
nós temos cardíaco, pulmonar, avaliação hemodinâmica, o FAST abdominal, os acessos vasculares, avaliação de via aérea e até o neurológico, como nós
and
podemos
it's
hoje
also neurological.
por meio da baía do nervo óptico. Quando se trata, então, aqui
When we talk about
exame focado
the
cardíaco
focused
sonográfico,
cardiac exam,
nós principalmente estamos falando sobre o
we're
cardíaco
speaking
em si
about
e
the
também
cardiac part
parte
itself
da
and also
avaliação
part of
hemodinâmica.
the
O que nós queremos com
dynamic
esse
assessment. How do we want? What do we want from a focused cardiac test? So I thought it was pretty interesting. This term was pretty interesting. It's responding in a way that our will be a binary assessment. So I want to think of the dilating hypertrophies, VE, VD. If there's any abnormality on the aortic valve, is there a yes or no dilating on the left side, hypovolemium, pericardiac effusion in a way that we also could define is it light or severe serious within the reasoning for an intervention, minimum change in conduct and the management of the patient. We started intensive therapy when it is a focus on the cardiac side to respond through basic information or stages that consume very little. Possibility has obvious pathologies like lung embolism, pericardiac. So of course there is limited training compared to a transexophagic, which first off, since the 80s has been incorporated into operation and intraoperationally. And you can see that I can complete the test in 4 seconds. I have a from 4 cameras applied for 3 seconds. I'm going to show you these windows now. Show this to you. Residents and non-cardiologists in the ICU, 5 hours of provision. They can give you a diagnosis in this way, in a binary manner. Is it leaves? Is it light, severe? Is there an intervention? No, intensivist is a diagnosis of 94% and with 84% of acceptance, meaning that within this assessment, we hope that will be a change in conduct, a more global assessment, a more widespread assessment than the binary sense that we mentioned. So I thought this paper was pretty interesting. It was 364 echocardiograms, rescue echocardiograms. We use this term when the patient is hypotense. They have a state that where the conventional monitoring, we couldn't reach a diagnosis of its cause. So we will be using and rescue ultrasound. You can see that out of these 264 exams, transthoracic and esophagic basic rescue exams, I found probably 80 transthoracic exams. So a main intraoperational cause, common surgical center with non-cardiac surgeries, two rooms that are hypovolemic and 24 and 6.6% is the most common diagnosis. You can see how this is you can see the very close incidences. It's important to know how things happen. We have VD, or the approach to diagnosis. There's some very big differences in treatment. Regional alterations and utility, 13.5%. Valve differences, we're going to follow a bit. Diastolic function is no less important. Maybe that will get away a bit of what we call to be the focus here, but we talk about that in your class, the reduction of the dilated vases for blockages. Also, the dynamic construction of the ventricular hypertrophic, less common. It's a more precise diagnosis that will generally is certainly more advanced. So these are the main things that we approach when it comes to what we call to be a focus. So I would expose a few of these situations here for us. Most of this class will be based on the narrative revision of our moderator, Fabio Papa, that made a great narrative revision specifically of the old cardiac focused ultrasound for non-cardiac surgeries. So going to speak about the focused ultrasound, the windows and cuts, you can see that with a few windows, there's an external window, we have this short and long, and theoretically 4 camera chambers, but I'm going to open up and speak about the 5 chambers where we can calculate the cardiac depth at the end and a subsymphoid window, which I consider to be an exception window. So the external window, so basically I end up in the 4th, 5th intercostal space, pointing out the right shoulder of the patient and our simulation center and cardiography on the São José Hospital to be able to show these directions and explain a bit of what we're seeing here in this window. So when we can visualize the right ventricle, the left ventricle, the cervical left ventricle, and the inferior side window, the left atrium mitral valve, aortic valve, aortic root, we can assess, for instance, there is an overload in the left atrium, the size will be proportional to the aortic size, and comparing the left atrium to the aortic region to see if there's any diastolic measurement, is this a normalcy, if the patient has a hypovolemia or not. So it's going to be moved in a correct manner and ventricular interdependency. So all of this is assessed in a CAT and region, which is pointing out the probe for the right shoulder of the patient. So our probe for the left, but on the right side of the patient's shoulder. So we have this image here of what I expect out of a normal test, the left ventricle, the right ventricle, the lower side wall. So it's an interoccipital wall on the exit side. So we compare this where the patient is hypovolemic, when they have a pericardial effusion, a noticeable pericardial effusion. We call this the racing ventricle. This is a ventricle that is dancing on this fusion that is it appears to be related to a voluminous chronic effusion. You can see that we have the lowering aortic side. We can see if the effusion is above it, belonging to the pericardium, if it's below, if it belongs to a pleural effusion, in this case, a lot of utility for the rescue of it. So continuing a bit with showing that it will be a patient that is hypovolemic. We see the wall actually have a position of the musculature, ventricular muscle, and after administering this, we could have a normal situation. So very quickly, we could diagnose what will be the main cause, the main incidence of the hypovolemia in the periparatory situation, even if it's not the ideal window for hypovolemia. We can still have an external side on the long axis showing the situation. So pathologies that I could have on serious patients that are interned to intensive therapy in the periparatory. I will assess what is normal, what is not, through a good training with hydraulic visualization, a normal patient that is training. So can tell it's a structure that should not exist, should not exist in the cavity. It's a left ventricle thrombosis on this window. It is noticeable. It's continuing the test. It's also there is also very serious valve pathologies. It's not one of the best videos, but speaking to Papa when I was talking, I was getting the class ready. Sometimes it's good to show a video that is not perfect because it's real world stuff, you know. We say we don't want just textbook stuff. We can see that it's an aortic valve. You can see the valve, we are opening this in the right way. You can see that the fires, they open the right way. You can see an opening and a closing of the aortic valve. The aortic valve does not have so much calcification, but you can tell the situation below the valve that is completely calcified. And it's that old story, you know, the valve is normal or not. Or the patient is getting to the surgical center, the emergency room to deal with a fracture. It's an older patient, but they're hypovolemic. The situation is similar to the one before, so you think twice about blocking and dilating with the aortic stenosis, which seems to patient that seems to be a noticeable situation. So simply turning on its own axis on the clockwise sense and pointing it towards the brain region of the patient, I have the external window on a short axis, so you can see the right ventricle, the relation V from VD. You can see that the volume is 1/3, tops 2/3 of the left ventricle. We can see relation of both chambers is the overload of the BD, where the acid would be assessment of the on the systolic basement or the diastolic phase. On the left ventricle, I can assess if there's an overload and pressure of BD on the septic, and hypovolemia if there is a position on the side and post-intermedial that they realize that this is a window that is very interesting window for anesthesiologists. So, and transthoracic side and the interior wall, this inferior wall, you can assess the regional perfusion. So here we have this image. It's a good relation to the VD with the left ventricle, maybe a bit of an alteration of the regional mobility on the lower wall, and the ventricle, you can see that it has a hypertrophic, completely hypertrophic ventricle. So with a noticeable degree of diastolic function. So we'll be a patient that is sensitive to vascular resistance situations of volume. 1 second. And continue with the external window. There's a situation here that I would consider to be a situation that is good to analyze in a rough manner. Systolic function without further concerns, which would be normal for a minor adjustment, but minor adjustments which are completely different from the situation. A patient that already choosing a direction that probably won't be above 20%. It's an important ventricle situation. It's not a differential. We're going to deal with this patient vasopressors. If they're they have hypotension, or we're going to think differently. Okay, I'm going to think about the load for the insufficiency. It's going to be an inotropic support. It's going to be transesophagic. Well, there's not a lot of difference when we are assessing the external window, but it's a transthoracic. So it's the comparison that is done accurately. So you can see the same relation to V with the VD. And I told you 1/3, 2/3 of the volume of the VD. And you can see when there is a noticeable overload of volume with the right ventricle, you can see the size actually with the ventricular interdependence, very little filling of the left ventricle. I can assess if it's the volume, if it is the same as the left ventricle. There's a noticeable situation. It's in my volume, and the volume is higher than the left ventricle. It's a noticeable dysfunction for the right ventricle. And here in this other case, I decided to show when there is a volume overload, or what happens with the ventricular septum. The window will be the same for externally. The visualization of the structure, so you can notice that this rectification of the septum, ventricular septum, happens. You can see how it rectified this though. The ventricular septum at the end of the diastole. If in the systole, beyond this, it's going to be an overload of pressure. The systole is not steady. It moves in the direction of the right ventricle. So it's very useful for us to see it as a rescue test. So the peak window, you can see that it's a bit more difficult. This window, there's no right intercostal space, but we need to try is in our physical examination, of course, the tip of the heart, feeling if we have, there's a ventricle, there is a direction of the probe for the left shoulder of the patient. And the posterior, we're going to have anterior lateral window. So the whole extension on average, basically, we can assess the global function of the ventricle, analyze a bit of the right ventricle, the atrium volume, mitral valve. There is a rough picture of the mitral valve. But it's a very important window on top of being a window that you can't do dynamic calculations to show you to see the cardiac depth. And even this peak window, all the time there is a noticeable deviation. In this case here, a deviation of the cardiac edge, but we can see that the volume, the left atrium compared to right atrium, is much higher than overload of volume, noticeable. You can see that the septum happens at the end of the diastole. You can see the ventricular septum. It's a very well-known sign of the left B-shaped ventricle. It happens in these cases. So you can see that the CAT scan chamber is at the tip of the ventricle. So you can see the real tip. It's not something for a focused rescue, but the true apex that I can do this transfer extraphagically. The cut would vary a lot depending on the ventricle. So it's a noticeable example on the right atrium. There's a discontinuity on the inner atrium. So let's see, on the ostium. As I said, these are rough assessment of a mitral valve that is completely calcified with an increased volume of the left atrium. We can have a stenosis. Mitral assessment with an impact on the management of a non-cardiac surgery. In the same way, I can assess effusions, pericardiac effusions, which happens, ventricle dancing on this effusion, huge effusion. Here it shows another rough alteration for a mitral valve with a prolapse valve, and as I said, it's considered to be some hostile window, because what happens that patients have a noticeable deviation. I can't see the whole heart, the walls that I want, but the patient has some sort of drainage being assessed post-operationally, and it's a window when 2-3 centimeters from the xiphoid and they directed towards the left shoulder of the patient. I can not only get this image of the left ventricle, which is similar to the peak or chambers, but with a slight deviation of the probe, the encephalic region. I have a brain region. It's an important symbol. The collapsibility of the chamber. It's analysis of limbic assessment. It's whether it's overloaded or not. This meeting on the right atrium. It's a very quick window for us to be able to assess this. We have a good coloration ventilation with echo contractions that are spontaneous. So there's a difference, a hepatic difference would be upwards. It's this comparison we have with dilation that is noticeable for chamber. So not only that, certain when an overload of pressure can have a, it's very noticeable to have a situation where you have an overload of the right side of the heart, not just femoral veins or the arteries, but we have veins, pulsating femoral veins. It's not normal. We can have a pulsating vein because it means that it's overloading and pressure of the right side of the heart. There's a bit of the ultrasound and a peak chamber, 4 chambers peak. But you take the extremities, distal extremities
colocando para baixo, o que eu
of
vou
the
fazer?
probe below. I'm going to direct it upward since the exit is anterior in the heart. You can see where the exit is. It's the lung, the prior VD on the thorax. You get the lung root, and you can see that it's anterior. So going down the probe, we have an excellent alignment with the Doppler. You can see the Doppler sign is here. The left atrium is empty. So it goes through that stretching. So it's considered to be cylinder. So a small guidance going up a sector, you can see it goes up a bit. I can make it happen that it goes through the exit path, and the exit path is a physical exit, is the middle speed. So we have the area of the base of the cylinder, which is in square centimeters, which is pi r squared. So we have the length in centimeters. I have cubic centimeters. So systolic volume, for calculation reasons, it takes the shape of a cylinder when it goes through the exit. So the systolic volume becomes the cylinder, which I'm going to calculate with my Doppler with the area, which is nothing more than this formula where I just need to have my cardiography device and calculate the diameter. We'll do so automatically, calculate the diameter of the pencil. It will calculate the voltage by R squared, and then I will distance the speed and time with the pulsating Doppler on the exit path. So the speed, the integral speed when I do this, or sometime what I have is distance in centimeters or L or H here to calculate the cylinder volume. So I multiply this by the cardiac frequency, which is number of cylinders that are going through the time unit. We have cardiac depth. So you can see and to integrate the speed over time with the Doppler will align with the 5 chambers. So we have a systolic volume, we calculate the cardiac depth. So you had the VTI. So you want to know if your cardiac depth is normal. So we place this VTI here above 18. So in this sense, it's a very good job recently published on BJAN, which shows that I can get alternate windows, like the external window, which is a bit complicated for you to get the peak window and align the Doppler. And we've had a lot of training we get intraoperationally to assess this. So you can think about whether you can calculate this at the head of the patient, and super external window has a good relation with the VTI when compared to the peak in this chart. So you can also use the variation of the systolic volume here with several Dopplers. You can think about delta PP, about the dimension of the speed, because the Dopplers are going through here on the screen. It's going through 50 millimeters per second. I'm going to use 12.50. We can see several envelopes in this unit where you can appreciate these several envelopes of speed through the left ventricle correlating to ventilation. So just picking up this, we can analyze this together with ventilation. You can see since it's spaced, still didn't finish the breathing cycle, and I can't analyze this jointly. So that's why we simply have
Com relação ao meu
on my
Doppler espectral maior, o menor no ciclo respiratório, e
so the
faço
lesser
o
breathing
cálculo
cycle,
para achar o delta volume sistólico, que deve ser maior
the
que
systolic
25,
volume,
menor,
which will be
desculpa,
12%. The 12%
23,4,
is at
teoricamente,
23.4.
claro,
So
isso
theoretically,
caso a caso,
case by
uma série
case,
histórica importante, talvez não seja
diastole may not be accurate, but the assessment of the systolic volume and the variation of the delta PP, we can use this with the echo as well. We can simply do what we just mentioned, the variations, the delta VTI, which is above 12% theoretically, the patient would respond to the volume according to the breathing cycle, and based on a calculation, we can see the minimum times 0.5. So no less importantly, when we advance with the echo rescue group, we can have an analysis of the diastolic function. If you can see that there's a percentage of patients that is not small. You can see here through that image that I showed you, 10% of the patients will have hemodynamic stability causing diastolic functions. Intraoperational patients that have sensitivity alterations that of ocular resistance, volume. So an analysis, not minutiae, but an analysis that is of the Doppler, which is going for the left atrium. For the left atrium, you can see that this is the Doppler transmitral Doppler, 2 initial thirds of the diastolis, which are responsible for the left atrium, the gauge gradient, so it's a larger. So you have the mitral valve, so on the left ventricle, and you have the P wave, and it will be an atrial kick. Normally, you have the situation which you are seeing here, which is the opposite of that is below the transexophagic, but the contribution would cannot go through, and theoretically of the acid emptying. So simply the fact assessing, a lot depends on the atrial side, and gotta remember those that were born from the deacceleration of the left ventricle. Since it's so slow, very quickly it ends up being a diastolic change, and you can explain a few causes of hemodynamic instability. So it's also training that could be simple and quick, maybe not minutious. I think it's important to have this because, well, when you're gonna be utilizing analysis of the responsibility of the veins side, with time, the patient has diastolic dysfunction, and you can't predict with this excellent paper on 129 patients assessed the collapsibility of the veins on patients going through a spine anesthesia to prevent hypotension. It was not prevented. Either rock curve, it's 615, so it's about 467. So 19.37% of patients had hypotension. So
Algum outro
we're still
exame?
missing some kind of test that could be done quickly. So there can be an assessment of patients that could go through instability. So can have rack anesthesia or hypotension. It's very important for our simulation center. So on the short axis, it's very accurate. So these volunteers, depending on the case, and to finish this, we can. It's a model that we followed the residents, the point of care generally. So I would show you this cardiac sensor. The proposal that I followed from 2019 or from 2016. So these are 16 minutes of theoretical class. So the practical with a simulation for 1 year, the mannequin. So the classes are generally online, and this is the curriculum that will be according to this paper. The point of care of PD, pericardiac. So also the collapsibility Doppler that I showed you, but I included in our curriculum here, the diastolic region. So it's simple. Know where the patient. So I know we will suffer severe instability. So depending on the surgeries, the thorax has a high incidence. It's important to have take care in the post-operatorial, always thinking about the Doppler sense that we included this here as well. So severe, perfect central, and arterial. So free liquid and the gastric is a very important, very quick test. especially seeing Mozambique, the airway, not just in positioning the lateral side, not centralized, but identification of the purgatory membrane layer has a possibility to have a difficult airway. So membrane itself, and we identified this, and I write this down first. Intracranially,
foi sugerido nesse paper de 2016 que a gente tem seguido, claro que isso
has
com
been
relação
following this according to the ultrasound.
mensagem para casa e para começar uma
So
segunda discussão
start a great discussion with colleagues.
E aí conduzida pelo Dr. Papa, ultrassom cardíaco focado deve ser
Focus
implementado
ultrasound must be implemented as a routine. I'm in favor of for sure on this. So we must make this systematic and always have the same routine. We must start with the external side, the short axis. We must make this systematic so that we will all never forget to have this examination. So thinking about the difference of the focused cardiac and transthoracic and non-cardiac. So it's a more widespread test and more minutious. Actually, that is not in a binary form. Training, we're gonna start thinking about this during graduation and the curricular explanation. So I am thankful for the participation, and now we have some time to discuss these subjects. So thank you, everyone. And just don't forget about following BJAN on the social networks, which is open access. It's well indexed. Several important platforms just to update the impact factor also, and congratulate you all. That's point 3.
Legal, parabéns
Thank
pela
you.
apresentação.
Thank you. Congratulations for your presentation. It's not the first time that we've seen you, but we always learn something new. Since I already said during the presentation, or Eric had, go ahead and send any questions you may have through the chat or for the Q&A. So I know we can't use the microphone, but I'm monitoring your questions, Eric. There are a few questions that are more practical, few less practical questions. And then we go for the less practical ones. We're thinking about focus ultrasound, surgical. So one of the biggest limitations of the focus ultrasound is the position of the patient. Most of the time is in the dorsal team, and we know that inclusion of the images and degree of difficulty is not the same. It does not change a lot the size of the patient, the thorax, the DTLC or not. Have any questions that you have from a quality point of view? What is your approach? Are you still? It has a few more responses. We're going to do this with easier ones. Which are the easiest windows for this test? I believe that the question being the intraoperational, on the anesthesia, on the mechanical ventilation, on instability, I want to use this as the rescue echo. And I tend to start with the external part. Our external side. It's easier, gives the field, and
enfim, rapidamente eu consigo essa janela. Também é bom descontinuar um pouco
so
a mecânica para ajudar também
mechanical ventilation would help lung structures to not bother the acoustic window.
Do ar, enfim. Mas o parasternal
So our external on the short long axis will give me a few good responses, simply because this. I mean, sure,
quero lá fazer uma reposição volêmica, guiar pelo
We
volume
have a
sistólico.
volume position lighted by the systolic volume.
Via de saída, consigo uns envelopes
You
bons
can
e,
get the good envelopes, and we're going to repose the volume, and then
a resposta ao tratamento com calma vão achar
very calmly I'm going to be able to find
só que algo importante
big side, but something important, if you're going to read it, it's a patient is going to suffer any instability intraoperationally.
guia hemodinâmico com ultrassonografia,
And ultrasound,
como guiar a anestesia pelo volume
you have guided anesthesia for the systolic volume.
É bom anotar antes também,
It's good not to be
né?
reported
Acha a janela
on the
antes
side.
anota,
You can write it down.
uma pequena marcação no
Have
paciente,
a small
vai
mark
ser
of the
mais
patient.
rápido de
It's going to be a
identificar,
lot
saber
quicker to
algumas
identify this
antes, né? Antes de começar a cirurgia.
before you start a surgery. In an urgent situation, you're not gonna be waiting. You're gonna have to have some kind of diagnostic exam. And for external side, on the long side, which is relatively easy to do on the side, but most of the patients, I would reserve the one. You need more training, and there's no point of trying to, because the patient and the echocardiograph, going to the laboratory, it plans with a well-positioned patient on the on their side, with their arm up. We have the best window possible on the side, and then you're gonna. There's no point in trying to have a well-positioned patient. It can frustrate us. It can frustrate the patient. If you have any more questions here, Eric, I want to know about you. The focus ultrasound. You don't have any experience. What about your use in obstetric patients? The ultrasound on obstetric patients, they have that questioning about a uterine size. It's gonna, and we think that obstetrician patients, we can, most of the patients can speak about that as well.
Olha, eu já comecei a minha era da ultrassonografia.
So I know by the time of the ultrasound,
fazendo já volume menor
using a smaller volume,
pacientes obstétricos, né? Mas assim,
obstetrical patients, and it was interesting because the first time where I used the transthoracic, have ultrasound on obstetrician patient, because I was scared because it seems like I was with a patient with cardiac insufficiency, and oh, it's a dilation point, and on the axis, mitral insufficiency, which is a bit beyond the minimal insufficiency. But it's a great window. So I think that on pregnant women, I think that just like our patients, non-cardiac patients, knowing about the physiological alterations of the station, there's about a 20% will have pericardial strokes, and the PD will seem to be dilating with a dysfunction of the chambers may be dilated in cardiopathic patients. That I know what are the alterations, physiological alterations. In that sense, we can think about a good test. I don't know if there's anything beyond this pregnant women. We can consider this to be, in this sense, but a systolic volume dynamic instability, C-sec, and also for neocardiac surgery. on pregnant women. Normally, due to the uterine size, and so a deviation of the size of the heart, it's difficult things to have with the image.
Subcostal, subxifoide, mas o paro external é bem tranquilo na maioria das vezes e o
Most of the time,
câmeras também fica mais facilitado.
it will be easier.
Duas perguntas aqui agora, eu vi agora aqui, a primeira da Ângela Sussumi, obrigado, Ângela.
Thank you, Angela. Eric, has it happened anytime that the external window and underside patient ends up hidden beyond externally? Without how you do this without interrupting surgery? Are there any tips, anything you can do?
Paciente em decúbito dorsal.
Patients underside, well, it's difficult because of the heart may be a bit more externally. You can do something to try to optimize this image.
Eu acho que assim, lidar com a ventilação
They're dealing with this
preferência, né,
with mechanical breathing, with assisted breathing. It can help kind of ventilation,
respiratório maior,
a higher amount of breathing time.
desligar o ventilador se for um caso de urgência para tentar.
If it's an urgent case, you try to find a good window.
Como eu falei, se eu já sei
And
que vai ficar em decúbito dorsal horizontalizado, marca antes e outra
if it's horizontal, you can
se eu
mark
cirurgia, se eu tô com
before you start a surgery. If you have an exam
prática para fazer,
test and you have no
questão
practice to do, and you know it's a difficult
começar a
matter,
cirurgia,
before you
eu
start a
tenho que
surgery,
janela, e se a
find the best
melhor janela
window.
for
And
uma
the
janela
best window of
clínica,
time is a
uma
window that
janela
is
que
limited,
consiga, fazer
that I can't
diagnóstico,
perform a diagnosis.
caso de ecotransofágico de
It's
resgate
an
torácico, né? Isso a gente
exophagic
não pode
case.
esquecer.
Basically,
O próprio FATE, quando o Jensen
so the fate
desenvolveu lá,
itself,
tá
that
lá
when
descrito, né?
describe
Quer
this,
dizer,
it's
ah,
described.
talvez
So
não o Jensen, mas
maybe
descrito nos primeiros papers sobre o FATE, né? Que é
about the focus exam,
siglas, mas enfim,
there are a
vamos lá,
few
o exame focado
numbers, but the
transoral
focus exam,
siglas. Se tu
tranextractic,
não consegue
if you can't
uma janela, tu
find a window, it's there.
é o quinto passo, tu aplica
And that's the fifth step.
adicional.
We
Aplicar ultrassom adicional.
can apply the
Básico,
ultrasound. That's a
resolveu o
basic
problema,
transexophagic.
pós-operatório,
It's
né? Assim,
and have
pós-operatório,
this
tá lá em
transoperational. So
o paciente está instável, vai avaliar no pós-operatório, não consegue a janela adequada, principalmente coração direito, viu tudo
so on the right hand of the heart, it's on the left side. Maybe there's a thrombosis located on the side. It's not going to be enough for diagnosis. We're going to have to go with transexophagic. Another thing that I didn't show here, but patients are at the intraoperational with a pericardic effusion. So for closed abdominal trauma, the cavity liquid, so you have pericardic effusion, it's unstable. So it's a lacerated or like so it's a beta blocker. I said resetics. First off, when it comes to the question of the colleague,
antes de tapar tudo.
so it's before we cover everything, before we're there before the surgery, that's in the middle. So mechanical ventilation, it's CET. If it's not successful, transexophagic, it's important to focus that we can't delay the treatment of the patient. So I think everybody's aware of that. So that's because of the matter of the window. So there's a few other. Eduardo Correa asked if the diameter of the left ventricle. It's a parameter that could be used as a target parameter of volemic replacement on the diameter of the left ventricle.
Parâmetro para reposição de volume.
Parameter for the reposition. I think that the volemic replacement is something that is very malicious to be able to use not just diameter for us to pick up a patient that get a patient that is dysfunctional from systolic acid. As I said, when I compared this to the short axis, on the short axis, we will have a calculation of that cavity. Doesn't go beyond 30 millimeters. We have a lesser limit of 39 millimeters. Try to hydrate this patient with H39 and have that systolic region. And I could actually use diameter, but first I need to know what tension I'm dealing with. The young patient and the diastolic diameter is lesser than 39 millimeters.
Se eu passei lá 250 ml de lactato,
so I have 150 milliliters. It's something that I showed you, Eric, sorry, but he added this in my comparing to previous echocardiogram. And comparing to the, this could be a factor to assess the upper volemic position. If you have a diameter, thinking about a preload, and if you can utilize this as a parameter for volemic position.
Medidas lineares.
You have linear measures of fire diameter. I don't think it's a good guide for volemic position. A good guide for volemic position is there monitors adequate to volemic position, and then will be the Doppler systolic volume as a standard. And then when you think of a chamber as a goal monitors that have systolic volume, you got a patient that is at a positive balance that is much lesser than normal. So when we look at the professional tests, it's excellent. So see that the mechanical breathing will alter diameter. Have a diameter. Intraoperationally, everything that we've done, medications that are altering the diastolic region, that we go beyond the point. I don't recommend to utilize this unless it's a case, let's say, that is as hemodynamic. Also, it's 45. The patient is hypertensive, 30. So from the point that the patient is stable linearly, so I think that it's in a unstable situation. So more than that, I don't know if Papa has anything to add. I agree with my reasoning, but I think that that's it. Yeah, the linear measures is it's a single dimension. Sometimes the patient has some alteration. So it's kind of a qualitative method of assessment. The systolic volume is a better image what is happening. So, and the vasovagal syndrome is confirmed continuously. But one moment before going back to the question, I'm going to answer this. It's we have the induction. Diminished quite a bit.
No final da cista está menor do que 25 milímetros, é uma boa avaliação para resistência
It's an
vascular sistêmica.
assessment for
O paciente
lower systemic
realmente responde a vasopressor, só para
for
complementar.
base
É,
pressures
teu
and
microfone vai falar mais a respeito de pré-carga, né?
from a preloads perspective also.
Tá, então manda aí. Síndrome vasovagal confirmada, como você aconselha a ultrassonografia contínua durante a cirurgia?
On the surgery and
Mas o que seria contínua?
Passar
Passar
so we go through transexophatic side,
o tempo com o transtorácico.
transthoracic time.
O que eu entendi,
And so what I understood is the continuous assessment for the procedure. Big advantage, the big disadvantage of the ultrasound.
Transtorácica é que você não consegue fazer avaliação contínua, né? Você consegue fazer seriada.
Well, it would be serial, and you can't leave the probe there the whole time. It's an advantage of the transexophagic, right?
Deixa lá se você quiser.
You can leave it there if you want to, and you can just monitor the transthoracic. You must, and when the time these things necessary. So maybe it's always good if you have any doubts, anything like that. Said, try to find a better window or basal measure and that measurement over time.
Eu acho que no sentido de fazer uma avaliação constante, deixar dentro do eixo fisiológico esse doente, não deixar ficar hipovolêmico, ficar com uma resistência vascular.
Don't be hypovolemic, have a good vascular resistance.
Eu acho que é uma excelente ideia, né? Porque de repente a contração a gente consegue
So the ultrasound, you can anticipate what kind of hypertension because you need the best vasopressors.
Lá faz uma bradicardia importante. A gente consegue de maneira, vamos lá, deixar o paciente
Wait for us to hemodynamic isn't working before there's any sort of instability. So if you're going to have these continuous sense, you're absolutely right. So yeah, I agree. And there are accessories that fixate the probe on the thorax wall.
Não existem, mas é difícil conseguir manter a mesma qualidade, mas é uma ideia, eu acho que é uma ideia.
It's an idea. It works. Think of having this image, have the information that you need, and everything should be fine. Eric, we're over time. So I wanted to thank you for your participation. And Andre, I don't know if you want to say anything before we close this. I just wanted to thank you. And Eric managed to stay within the time, and that's a big, that's beastly. Yeah, so a lot of time he goes 3 times over time, so much knowledge, but today it was great. Well done. Congrats. Incredible. Yeah. Andre, Eric, Mel, everybody, thank you for your participation. So whenever we're here, we're available. Thanks, everybody. Good night. See you.
Gente, obrigado. Tchau, tchau.